Amiodarone causes thyroid dysfunction by virtue of the high iodine content. It can cause hypothyroidism, hyperthyroidism, and thyroiditis. Amiodarone is one of the most widely used antiarrhythmic drug. 200 mg of amiodarone daily would deliver 20 to 40 times the usual daily iodine intake. Hypothyroidism occurs in iodine sufficient areas and hyperthyroidism occurs in iodine deficient areas. Amiodarone reduces 5-deiodinase activity and thereby the monodeiodination of T4 to T3. There is decreased generation of T3 and reduced clearance of reverse T3 which accumulates. Destructive thyroiditis is due to the direct toxic effect of amiodarone and its metabolite on thyroid follicular cells. Screening for pre-existing thyroid disease and thyroid function prior to initiating amiodarone are ideal in cases where the drug is being started on an elective basis. Thyroid scan results may not be interpretable once a significant dose of iodine in the form of amiodarone has been delivered into the system, especially after an intravenous initiation of therapy in life-threatening situations. Periodic follow-up with thyroid function tests are also recommended while on long-term amiodarone therapy. Thyroid stimulating hormone level is one of the earliest to rise with amiodarone and can occur as early as 48 hours, reaching nearly 3 times the normal levels by 10th day. Amiodarone-induced hyperthyroidism is less common than hypothyroidism. Amiodarone-induced hyperthyroidism has been classified into two types. Type 1 due to excessive iodine-induced synthesis of thyroid hormone. Type 2 is due to amiodarone-induced destructive thyroiditis. Type 1 amiodarone-induced hyperthyroidism can be treated with withdrawal of amiodarone if the clinical condition permits. It may be noted that due to the long half-life of amiodarone, stopping of the drug may not bring any immediate relief of hyperthyroidism. Moreover, there can even be an initial worsening as amiodarone blocks peripheral conversion of T4 to T3. Very often, the clinical condition may not permit withdrawal of amiodarone as it is often used for life-threatening cardiac arrhythmias. If withdrawal of amiodarone is not an option, treatment with thioamide drugs like carbimazole, methimazole, or propylthiouracil may be needed. Higher doses of these drugs may be needed due to the high iodine levels in the body. Though propylthiouracil was initially preferred for amiodarone-induced thyrotoxicosis as it reduces peripheral deiodinase activity, a safety warning has been issued due to its potential liver toxicity. Amiodarone-induced thyroiditis may be treated with corticosteroids. Antithyroid drugs may be needed in certain cases. Some of these cases of amiodarone-induced thyroiditis with hyperthyroidism may eventually become hypothyroid. Other therapeutic measures like thyroidectomy, plasmapheresis, lithium, and radioiodine ablation of thyroid are reserved for refractory cases of amiodarone-induced thyrotoxicosis and seldom needed. Amiodarone versus sotalol for atrial fibrillation trial sub-study involving 612 patients documented subclinical hypothyroidism with TSH levels between 4.5 to 10 milli-international units per liter in 25.8% of those treated with amiodarone. TSH levels above 10 milli-international units were noted in 5%. In older males, hypothyroidism developed in about 30.8% of cases. Permanent hypothyroidism is likely to occur in those with thyroid antibodies indicating thyroiditis. Amiodarone-induced hypothyroidism can be treated with levothyroxine supplementation if the clinical condition does not permit withdrawal of amiodarone. Those without pre-existing thyroid disease may become euthyroid within 2 to 4 months of stopping amiodarone in clinically permissible situations. Initial set of references for amiodarone and thyroid dysfunction. Final set of references for amiodarone and thyroid dysfunction.